So good evening, everyone. Welcome to today's CPD on the first module of the RAAS fact checking. So my name is Zelia Oboshi Ago. I'm a pharmacist with Sevier and with the hypertension business unit in Kumasi. And I'll be your moderator for today's CPD. So also during the course of the presentation, please, if you have any questions, kindly put it in the comment section for us. Thank you. So this CPD will be in 3 sessions. The first would focus on the pathophysiology of RAAS inhibitors. And to help us facilitate this session is a consultant cardiologist and senior specialist physician at the cardiology unit of the Department of Medicine, Komfanochi Teaching Hospital. He doubles as a lecturer at the KNUST School of Medical Sciences. Ladies and gentlemen, I present to you Dr. Yao Edubuachi. So, Dr. Yao Edubuachi, over to you. Thank you.
Okay. So good afternoon, everyone, and I hope I can be heard, right?
Yes, please, Dr. Yao Edubuachi, you can proceed.
Okay. So this afternoon, a very tight time for all of us because we should have been at the stadium cheering our footballers on, but I hope we'll be able to finish in time to join them. So we have already introduced what is going to happen this afternoon, and in the next 20 minutes, I will try and speak about the pathophysiology of ACE inhibitors and then ARBs, focusing actually on RAAS and then bringing in these two molecules that we use for treating hypertension. And it's actually just a fact checking time. So just to bring in the facts that ACEs and ARBs have been in the system for a long time. But do we think there are any differences in terms of pathophysiology? And then I'm sure Dr. Lambert will also come in with another aspect of it, focusing on hypertension. So what we know traditionally about ACE inhibitors and ARBs, I mean, with respect to RAS, is that the Renin Angiotensin Aldosterone System is actually a system that um, is actually activated. So it's basically a homeostatic system that comes into play after the basal receptor system has actually come in to, stabilize um, blood pressures when it comes to the acute phase. So the basal receptor system is the first phase that comes in when there is a reduction in blood pressure, reduction in, in blood volume, so that it brings back the blood pressure or the blood volume to normal. But when those mechanisms are not enough to be able to control that, then the renal angiotensin system is actually activated in a more chronic stage. So really, the RAS system is not a bad system. It's a system that seeks to keep things in place. But when it is perpetually activated because the triggers sometimes are not taken out, so an insult on the heart, an insult on the kidney, an insult on the blood vessels continues, then the system perpetually comes in, and then the negative effects of that system begins to come, and we begin to feel that in the form of hypertension or in the form of some renal damage, or we may begin to see the clinical implications of that in the form of heart failure or heart enlargement or sometimes stroke and then other vascular events. So we kind of know how the system works, and therefore we won't bore ourselves with the how the pathophysiology has been in the normal sense. The physiology is in the normal sense, but we'll look at how the pathophysiology runs. So this was put together by this scientific steering committee. What I'm going to present, and I will be the one to speak through it at this point in time. In terms of disclosures, I think this will really belong to Sevier, which put this program together. Um, what will be our learning objectives? So the first thing we want to know in terms of pathophysiology, is there a difference between AC and ARBs? And also, is there any evidence that speaks to the fact that ACEs and ARBs are different when it comes to endothelial function, fibrinolysis, and then cardiac protection? And also, we move into the basic science, whether clinically we could have a difference in AC and ARB when it comes to how we apply these medications on the ground. So a few facts. These are 4 facts that we will go through, and we would want each and every one, as the questions come, to follow and ask yourself, or whether you know that is true or false, or whether you don't know, and therefore by the time we go through the presentation, you'll be able to pick whether it is true or false. So the first thing that we want to, acquaint ourselves with is AC inhibition, and then AC inhibitors, and then angiotensin receptor blockers. Do they have a different action when it comes to renin angiotensin system? And also the bradykinin system, does it have a different, you know, end effect if ACE or ARBs are applied. And then when it comes to the endothelial function, are ARBs and ACE inhibitors, are they different? And also fibrinolysis in terms of breaking down and thrombosis. Is ACE inhibition and then or angiotensin receptor blockers, do they apply differently in this matter? A lot of studies have gone on. So this that you see on this slide actually shows that we've had about over more than 20 trials, but this has picked about 20 of them, looking at telmisartan, losartan, valsartan, ibisartan, candesartan, perindopril, lisinopril, and enalapril. That in the real life, when these studies were done, at the end of the day, like I said, we are looking at the endpoints in terms of mortality. But this actually picked out the all-cause mortality, so that this mortality, whatever cause of the death of the patient, in terms of, when we look at the population, we looked at whether ACE inhibition or ARBs, which were being used in antihypertensives, made any difference. And if you look at this slide, it actually speaks on the fact that if you look on the side of the ACE inhibitors compared to the ARBs, you begin to see that the hazard ratio for most of the ones on the ACE inhibition side is more than one, which actually means that it has a lot of benefits when it comes to all-cause mortality. So anything that can lead to death in the population, when patients are given ACE inhibitors compared to ARB, it looks like inhibitors are on the more positive side. Now, if you put away all-cause mortality and you decide to narrow down on things like the cardiovascular death, myocardial infarction, stroke, new heart failure onset, and also new diabetes onset, you look at the odds ratio and you realize that the odds seem to be in favor of the ACE inhibitor. Those are the ones in red. And you realize that the odds for somebody getting a cardiovascular death, myocardial infarction, stroke, and all those things that are here, the odds are lower when it comes to ACE inhibitors compared to ARB. So in the scientific world, some meta-analysis that has been done actually even point to some sort of superiority of ACE inhibitors when is compared against ARBs. So the factors, let us ask ourselves this question. ACE inhibitors and ARBs, do they have different actions on renin angiotensin system? And let us go through and decide. So when you look at this slide, it brings us back to what we know traditionally, that when blood volumes go down or blood pressures go down, renin is actually released from the juxtaglomerular apparatus, and then it breaks down the angiotensinogen that is produced from the liver into angiotensin 1. And then angiotensin 1 gets into the bloodstream, is carried to the lungs, and the lungs, ACE, is actually produced to convert the angiotensin 1 to angiotensin 2. Now, angiotensin 2 begin to act on a specific receptors. That is angiotensin-converting, angiotensin AT1 receptor, which is angiotensin receptor 2 blocker type 1. And when that one acts on it, we know that AT1 receptors begin to give us some deleterious effects because we begin to see vasoconstriction, hypertrophy, fibrosis, inflammation, and proliferation. And all this happens because the angiotensin 2 that is produced begin to act on the smooth muscles. It begins to act at the level of the cortex of the adrenals to produce aldosterone. And we know that aldosterone can produce all these effects. Also, at the level of the posterior pituitary, begins to release anti-diuretic hormones, and we begin to see some of these effects come up. And also, we have sympathetic nervous activation, and therefore these actions come up. Now, if you look at this, you begin to see that there's also another pathway, which hitherto a lot of people didn't know, but a lot of recent advances in trials have actually brought our mind to the fact that when angiotensin 2 is produced, it also begins to get degraded. And this is actually done by a homologue of the ACE, which is the ACE2, and begins to produce what is now known as the angiotensin 1,7. And angiotensin 1,7 acts on the G protein coupled receptor, which is known as MAS, and begins to give a counter-regulatory effect to the AT1, actions, so that we begin to get vasodilatation, anti-fibrosis, and also anti-proliferation. So in actual fact, now the new ideology about the use of these ACE inhibitors and ARBs have been that there's a balance between the ACE, angiotensin 2, and also AT1 receptor. Then on the other side, ACE2, angiotensin 1,7, And the mass is what actually decides what happens at the level, molecular level, and also at the cellular level. So we'll go on and then see. So at the cellular level, angiotensin 2 actually does almost everything that we talked about and actually leads to hypertension and also promotes thrombogenesis. And therefore, we begin to see more cardiovascular effects in terms of strokes and also heart failures. When on the downside, you begin to see endothelium being, promoted, more vasopressin, and therefore you get endothelial dysfunction as a result of the activation of angiotensin 2. It's in this regard that these two antihypertensives were produced so that they could actually reverse these effects. So ACE2, as I've already spoken about, is actually a clearance enzyme. So it comes in to clear the angiotensin 2 that has built up. And these are actually expressed more when patients have pathologies like diabetes, heart failure, myocardial infarction, and hypertension. And therefore, it seems to us that with this ACE2 that has been discovered, its clinical effects would be that it will bring down the levels of angiotensin 2 and also lead to the promotion of angiotensin 1-7, which will be a counter-regulatory mechanism. When these pathological events have started, it will be able to help us to bring about the reverse effects of these ones. And studies actually have shown that apart from the AT1 receptor, there's also another receptor called the AT2 and AT4. And this usually acquires most of the time when angiotensin 2 has been produced because it usually acts directly on the AT1. But then when these are overstimulated by the AT2 and they are overstimulated by angiotensin 2, then we begin to see in the chronic phase of AT1 inhibition, a lot more production of angiotensin 2 begin to overstimulate the AT2 and AT4. And we'll come to see that AT4, after it's stimulated for a longer time, begins to promote what we call the plasminogen activator inhibitor, which actually sets off a lot of thrombogenesis and begins to predispose people to development of myocardial infarctions and stroke and other things. And therefore, it's it tells us about the fact that when ACE inhibitors are used and ARBs are used, we begin to get different concentrations of plasma, the angiotensin 2, because ACE blocks at the level of, at before the production of angiotensin 2. And then downstream, you have angiotensin 2 receptor blockers coming in to block at the level where angiotensin 2 has already been produced. And therefore, it stands to, a reason that there will be more concentrations of angiotensin 2 when you use ARBs compared to ACE inhibition. And studies really have shown that after 48 weeks of use of this in antihypertensive patient and hypertensive patient, this is what we see. But on the other side, when ACE inhibitors are used, it actually brings down the level of plasma ACE almost completely. But then what happens is that angiotensin 2 is not blocked off completely because there are other pathways through which ACE angiotensin 2 is stimulated. Usually we have the non-ACE pathways and also the non-renin pathways like kinase and also a tissue plasminogen activator, which is a non-renin pathway. And therefore, after the inhibition of ACE in the serum, you'll still begin to get angiotensin 2 production, which comes off. Previously, this was, used against ACE inhibitors that they are not able to block off angiotensin 2 completely. But now the new evidence that is coming shows that the levels of angiotensin 2 that stays around temporally is able to go back shunt into the pathway where the ACE2 is able to move it to form angiotensin 1-7 and begin to give us a counter-regulating mechanism against the proliferative and the fibrotic, changes that happen with angiotensin 2. And therefore, with this submission, I believe that at this point, all of us will be able to appreciate the fact that angiotensin inhibitors and ARBs have different actions on the renin angiotensin system, in that they end up producing different levels of angiotensin 2. And the very high levels of angiotensin 2, that happens because of the blockage at that level. The AT1 receptor actually has deleterious effect on the AT2 and AT4 receptors after some time. But when it comes to ACE inhibition, because that one is temporal, you get it getting, siphoned into the production of angiotensin 1-7, and that has very good effect. So the first check would be considered as true. So there are different mechanisms actions on renin angiotensin system. Also, we have the second question to ask, and I'm sure most of us know what bradykinins are. Do ACEs inhibitors and the ARBs, do they have a different effect when it comes to the bradykinin system? So let us go through and see. So we have the canequins that comes in to break down the canecogens into the bradykinins. And usually when ACE inhibitors are used and they block off the ACE, at the end of the day, they also block off the degradation of bradykinin into inactive fragments. And once there's a block off, you get a buildup of the bradykinin. And that is what usually sometimes be the side effect that we see with ACE inhibitors. That is actually the cough, and also you begin to get the angioedema sometimes with ACE inhibition. But suffice it to say that just like now we are beginning to find out that the BMP is an important pathway when we usually block off the sympathetic nervous system and all the RAAS. We are now also finding that the bradykinins are able to cause vasodilatation, natriuresis, and diuresis. It's been there all this while, but whether its utility and its understanding has actually come in the light of the physiology that speaks about AC inhibition and ARB have actually been in the dark until recently, when it's been found that when ACEs are used, the buildup of the bradykinin actually promotes the good effects of the vasodilation, the good effects of the bradykinin, which is vasodilatation, the natriuresis, and the diuresis. And these effects are positive when it comes to endothelial function. So if you look at this bar chart, you begin to see that for a patient who has coronary artery disease, for instance, if they are given ACE inhibitors, you begin to see that after some time, this is after 1 year, you realize that there is about 20% increase in the bradykinin levels of these patients. And therefore, it stands to say that they begin to develop the positive effects that the bradykinin bring compared to the control. And therefore, it's easy for us to at this time to say that when we use ACE inhibitors, we promote bradykinin, a buildup, whilst ARBs have no effect on bradykinins because they block at the level of the AT1 receptor. That has no effect on the bradykinin pathway. Now, checking three, ACE inhibition and then ARBs. We are saying that they have different effects on the endothelium function. Is that true? Is that false? Or is this something that we don't know? So let's go through and see. So when it comes to the endothelial function, you know, we all know by physiology that it contributes a lot to our cardiovascular health and function. And suffice it to say that we've been taught over the years that hypertension has we don't know the cause of hypertension. So basically, people talk about the fact that we have primary hypertension and the cause is unknown. But as you advance, you begin to appreciate that what we think is unknown is actually caused by endothelial dysfunction. And that is why age is a strong factor for the development of hypertension. So that as people age, they begin to develop high blood pressures. And that is because the endothelium, which hitherto is supposed to regulate a vascular tone and also control the blood pressure flow and also actually regulate the production of cytokines and adhesions, begin to undergo a lot of changes because of the vasoconstrictors that are produced from inflammation. So some of the vasoconstrictors are the endothelins and the angiotensin 2. And when these are promoted, they begin to cause endothelial dysfunction as against a normal endothelium function. And therefore, what happens in the early what we begin to see in people who have developed hypertension and those who are subjected to other risk factors is that we begin to see a decline in their function. So if you look at this, for instance, this was where they did check the endothelial forearm blood flow, which is actually a non-invasive way of actually checking what happens at the periphery or the microvascular perfusion. And we realized that the graph shows that those who were hypertensive had a lower blood flow after some time. So it shows that constantly endothelial dysfunction will predispose people to hypertension. And otherwise, it's the same. So once you develop hypertension from endothelial dysfunction, it becomes a cycle because the hypertension itself is a risk factor that keeps on promoting endothelial function. And when that happens, we get a promotion of inflammation, we get thrombogenesis happening, and also a very compromised response to vasodilators. The other thing that happens is oxidative stress. So as hypertension has developed, other factors that we get from our food, for instance, um, low density lipoproteins, when we are not exercising, people developing diabetes and smoking. And all these things certainly will go through what we call the metabolic pathway and lead to endothelial dysfunction and then begin to promote all the things that we see here, remodeling, smooth muscle cell growth, and platelet aggregation, and therefore will all end up in the in the cardiovascular disorders. Now, when it comes to ACE inhibition and ARBs, what then would its role be on the endothelial function? So, like we have already alluded to, when the bradykinins are increased and they are left unattacked in the situation of ACE inhibition, they begin to promote increased nitric oxide. They begin to increase prostaglandins, and we know that nitric oxide and prostaglandins are the two powerful endogenous, vasodilators, and therefore it helps to improve, endothelial function. On the other end, because ARBs will block the AT1 receptor, it begins to build up the angiotensin 2, which begins to act on AT2, constant stimulation of AT2 and AT4. And the AT4 begins to produce a lot of PAI, which is a plasminogen activator inhibitor, which is a very powerful risk factor when it comes to the development of myocardial infarction. We'll come to see. And the AT2 receptors also begin to cause vascular remodeling. And therefore, we will say that on the side of ARBs, it may end up leading to endothelial dysfunction. Whilst when people receive ACE inhibitors, they, through the pathway of the bradykinin, will begin to promote endothelial protection. And that is where the difference comes. Different hypertensive were also studied. And if you look at this, you look at the lisinopril, the calcium channel blockers, and the beta blockers, and you realize that for the flow mediated endothelial dependent dilatation, which is like what I spoke about. So you try to create a certain level of hyperemia or reactive hyperemia, and then you open the occlusion again and then see how the flow goes, because that tells us about the microvascular perfusion. And you realize that of all the drugs, after 6 months of use of these drugs, perindopril stood out with about 6.4 as compared to the all others. And this was quite close to like somebody who was a normotensive who didn't have hypertension, which did about 7.1, and that was very statistically significant. So it speaks about the fact that the ACE inhibitors have a lot to do when it comes to endothelial function. Now, if you look at this, another study that looked at the post-myocardial infarction patients, because these patients, through apoptosis and also the stimulation of tumor necrosis factor, they begin to do remodeling of the areas where the myocardial infarction happened, the vessel and also the myocardium. But you look at the perindopril group compared to the valsartan group, and this publication was somewhere in the 2011. You realize that those that receive ACE inhibitors, they decrease the rate of apoptosis and also increase the vascular endothelial growth factors that promoted the regeneration of the vessels. And then the tumor necrosis factor, which otherwise would set off a lot of inflammation, actually went down. And therefore, it stands to say that ACE inhibitors, but not ARBs, decrease pro-apoptotic effects and also increase the renewal of endothelium in patients who have had acute chronic syndrome. And therefore, when we have to make a choice, we should be guided by physiology. And these are studies, I think I'll skip this, which show that quite a number of all these drugs do some level of endothelial, improvement. But if you look at this study, for instance, then you see that the maximal forearm blood flow hyperemia, again, another study that trying to look at the various drugs also still brings the fact that ACE inhibitors is actually superior when it comes to the other drugs. The only drawback to this study, which I have to admit at this point, is that ARVs are not easier, but we have already seen that one on another slide where ARVs were also used. So in the long term, when it comes to endothelial dysfunction, inflammatory markers are also things that we look at. And we want to see, has there been any study that has looked at ARVs, which actually has promoted either a good effect, a negative effect, or no effect? Now, this study that was done in a huge number of patients, so over 400, you looked at ARV and made a hypothesis that if ARVs would decrease inflammatory markers, they were thinking that after some time, in the long run, you may get the pro-renin pathway, bringing back the cytokine production so that to counteract that effect. But after the study went on for a long time, after 5.4 years, they made a conclusion that ARBs have no associations in terms when it comes to inflammatory markers. And that leaves us in a situation where if somebody has myocardial infarction or endothelial dysfunction, ARBs may not really do much compared to ACE inhibition that causes reduction in inflammatory markers. So, on the fact finding three, we can say conclusively that ACE inhibitors and ARBs have different effects when it comes to endothelial function. Now, the last of the facts is the fibrinolysis. Does ACE inhibition and ARB have affect fibrinolysis differently? And when it comes to fibrinolysis, we are looking at where we promote the breakdown of thrombus, and that will be a good thing when it comes to endothelial function and also cardiovascular endpoints. So we are saying that naturally, the endogenously, fibrinolysis is a natural defense, like I said, to break down thrombosis so that we don't get vessel occlusion. And the two things that keep this balance is actually tissue plasminogen activator and also plasminogen activator inhibitor. The plasminogen activator inhibitor, when it's activated, actually leads to the formation of more clots. And rather, tissue plasminogen activator, which is even used in the in the ICU, actually to thrombolize, actually break down clots. So when there is a balance, the balance takes in favor of the plasminogen activator inhibitor, people develop a lot of cardiovascular risk. And then on the other hand, if you have more tissue plasminogen activator, then you get the thrombogenesis happening and then vessels become potent. So we are saying that AT4 receptors, as has already been mentioned, usually quiescent. But after we have blocked the AT1 receptor by angiotensin 1, angiotensin 2 receptor blockers, it actually leaves the AT4 pathway permanently stimulated by angiotensin 2, which builds up and usually leads to the release of plasminogen activator inhibitor and is a major inhibitor of fibrinolysis. And it's also been found to be a very powerful independent predictor of death after people have developed myocardial infarction. And therefore, for the same reduction in blood pressure, so these drugs we are talking about today, beyond blood pressure reduction, if you give ACE inhibition and ARBs, it may give you the same amount of blood pressure reduction, but beyond the numbers, ACE inhibition will offer a greater, reduction in plasminogen activator inhibitor, and that will be a good effect. And that's happening in patients who are actually insulin resistant and are hypertensive. So these are metabolic syndrome patients who have a very high risk when it comes to, cardiovascular events. And this is a diagrammatic to show that. So this bar chart here actually shows you that ACE inhibition, the one in red, actually decreases your levels of PA1 compared to ARB, which is in the blue. And also when it comes to TPA, they are both apart. So you would rather choose an ACE inhibitor when you have some of these events so that you decrease the thrombogenic rate with the ARBs. And when you look at it in terms of the pathway, it stands to say that ACE inhibition would increase your tissue plasminogen activator because the bradykinin are increased. And through that same pathway, it will stimulate TPA. But on the other side, because we are blocking off, because we are producing a lot of angiotensin 2 as we give the ARBs, we increase angiotensin 2, which actually act on the AT4 receptors. And we begin to produce a lot of PAI, which is the plasminogen activator inhibitor, and therefore predispose to thrombogenesis. And therefore, how do we so at the end, it brings us back to the same thing that the ACE inhibitors in ARBs have different effects on AT4. And how do they affect AT2 as well? Now, AT2 are poorly expressed under physiological conditions. So AT1 is blocked, but AT2 receptors have some physiological effects which are good: vasodilation, preventing apoptosis, and then anti-proliferation. Now, it's quiescent usually when people don't have a lot of events, but when events come up, then the numbers increase. But once we block off the AT1, we begin to overexpress these receptors because a lot of AT and angiotensin 2 is produced, just like it will do for the AT4. It begins to act on these ones, and then the effects that are seen under pathological conditions are usually not good. But on the contrary, for ACE inhibition, because it doesn't go through that pathway and blocks off the ACE, we don't get a buildup of the angiotensin 2. But what actually happens is that for the non-enzymatic, the non-renin and the non-ACE pathways, we begin to get kinase and tissue plasminogen activator producing angiotensin 2 in about moderate numbers after some time. And that one is shunted into the ACE2 pathway and becomes the angiotensin 1,7. That then begins to stimulate AT2 and AT, and that begins to stimulate AT2. And therefore, we begin to see the positive effects of these, um, of these medications. And therefore, ACE-I and the ACE2 act differently when it comes to ACE inhibitors. ARB will act differently when it comes to AT2 receptors, where ACE1 will promote a good effect, but ARBs, on the contrary, they begin to give you the negative effects. So, if you look at this in terms of mechanism, you are saying that if somebody receives ACE inhibition, you inhibit ACE, and then you begin to see the effects of the ARB on the AT2 receptors going up. So all these we've spoken about. By the end of the day, you come to get increased bradykinin in the ACE inhibitors, and also you get nitric oxide going up on the side of the ACE inhibitors, while there's no change when it comes to ARBs. And therefore, nitric oxide begins to promote um, endothelial, function. Whilst on the other side, ARBs doesn't seem to do much when it comes to endothelial function. And therefore, what conclusion do we come to? ACE inhibitors and ARBs affect fibrinolysis differently, and that is true. So, having presented this, what will be our key message? Now that we know that the pathophysiological pathways are different for ACE inhibitors and ARBs, and that we know that their effect on AT2 is different, and now we know that there is a homologous ACE which goes to another pathway to be able to produce the angiotensin 1,7, which has positive effect. And therefore, now the balance between ACE, angiotensin 2, and the AT1 as against ACE2, mass, and then the angiotensin 1,7 is what actually brings what we see in the physiology of these two drugs. We will say that when it comes to blood pressure, ACE inhibitors and ARBs would have similar effects. So when it comes to BP control, we may have similar reductions in blood pressure. But when it comes to the incidence of myocardial infarction, with the activation of the plasminogen activator inhibitor, we may have higher events in ARBs. And then what about the angiotensin 2 levels? ACE inhibitors temporarily decrease the angiotensin 2 levels and constantly increase the bradykinin pathway, and therefore lead to much production of the nitric oxide. And therefore, it will lead, when ARBs will lead to overactivation of the non-AT1 receptors, and AT4 will bring the deleterious effects. And AT2 also produce some deleterious effect, basically remodeling. And therefore, we should be able to think about our choices when it comes to ACE inhibitors and ARBs. Now, both ACE inhibition and then ARBs will reduce blood pressure, but it seems that only ACE inhibition will do some level of cardiac protection based on what we have presented. ARBs, therefore, may have to be reserved for use in patients like the guidelines will always state who have intolerance when it comes to ACE inhibition. So you give somebody an ACE inhibitor and he begins to call for have angioedema, then your hands may be tied and you may have to replace that with the ARV. And usually what we see is that we may get about, when it comes to angioedema, you may get 1 out of 1,000 patients developing angioedema on ACE inhibitors, and a cough, maybe 3 out of about 100 patients developing a cough. And even there, sometimes it depends on how bad the cough is. So the cough is something that is not so much every time. You may decide to keep your ACE inhibition if it doesn't disturb the patient. So the difference in clinical outcomes, which are observed with ACE inhibition and ARVs, can be explained actually by a lot of well-established pharmacological data, and some of these are what we have presented this afternoon. Thank you.
Thank you so much, Dr. Dubois, for the education and for laying the clear and concise differentiation of the ACE inhibitors and ARBs, and also fact checking the four major misconceptions as well. So to take us through the second session on the clinical evidence of RAS inhibitors is our second facilitator. He's also a consultant cardiologist and also a senior specialist physician at the cardiology unit at the Department of Medicine, Komfanochi Teaching Hospital. And he's also a senior lecturer at the KNUST School of Medical Sciences. So, ladies and gentlemen, I present to you also Dr. Lambert Tete Apia. So, Dr. Lambert, over to you. Thank you.
Thank you very much, Zelia, and thank you so much for setting the stage here for some evidence that's available to support what you have said. Indeed, hypertension is a big issue, and before I go on, I'd like to acknowledge the steering committee that puts this slide together, and also to thank Sevilla for putting this educational campaign or program together. Thank you very much for the opportunity. So enough has been said, and it's our objective to try and look at some issues regarding blood pressure, measuring targets, and the evidence that ACE inhibitors and ARBs have so far to inform our choice of antihypertensives. Again, we'll differentiate between ACE inhibitors, whether or the benefits that ACE inhibitors have is a class effect or there are still intra-class differences. Then we would make the case for combination therapy for uncontrolled hypertension. So enough really has been said. And in this segment, again, we were looking at some facts or fake news, and it will be a bit interactive. So we'll have about 7 facts to either accept or debunk. So the first fact is a single office blood pressure measurement is sufficient for hypertension diagnosis and treatment control. Is this statement true, false, or we don't know? So you can just spend a couple of minutes on this, and then we can move into what the data says. A single office BP measurement, is it okay to diagnose hypertension, and does it help in treatment control? So as the current guidelines of the European Society of Cardiology will have it, there are various grades of high blood pressure and what you should do when you have a patient whose blood pressure is optimal. So anything less than 128 is optimal. So for such an individual, you can decide to repeat blood pressure every 5 years. If you do and the blood pressure it's normal, that is, has gone beyond optimal, you can also repeat such BP readings every 3 years. The interesting bit comes in when the patient has high normal blood pressure and you don't know if this is a case of white coat hypertension because the doctor is there or the patient is in the clinic, that's why the BP is gone up. Or is the case that this patient, even when he goes home, the BP is higher than what you're seeing in clinic. So it's either marked or white coat. For such individuals, it's important to repeat the blood pressure. But in such individuals also, we do have a role for what we call the out-of-office blood pressure measurement, where you can do an ambulatory 24-hour blood pressure monitoring, or you ask the patient to measure his blood pressure twice a day for between 3 to 7 days and show the numbers to you in clinic. Then you can compare whether blood pressures at home are fine, but when it comes to clinic, they are high. Then you can decide that this patient is a white coat hypertensive patient, or if the reverse is true, then it's marked hypertension. So there's a role for this out of office blood pressure, particularly for those with high normal blood pressure. Of course, if you check the blood pressure and it's 140/90 or above, then it's still important to confirm this blood pressure. So either you ask this patient to come to a clinic a couple of times within the week to get it checked, or once again, you can use the out of office BP measurement to see if indeed this patient has sustained hypertension. So these are the cutoffs as the guidelines recommend. So in the office, anything 140 and above systolic is enough to qualify for hypertension. If you did an ambulatory blood pressure monitoring, the daytime cutoff is anything 135 over 85 or more. At night, we expect a normal or a natural dipping in the blood pressure between about 10 to 15%, and therefore nighttime thresholds are lower, so 120, 70. The 24-hour, which is the mean of both the day and night, is somewhere in between the two, which is 130, 80 as the cutoff. It is important to recognize here that if you're unable to do ambulatory blood pressure monitoring, either by cost or availability issues, then there's some evidence that the home blood pressure monitoring, the mean of the home blood pressure readings that you check, correlates to the daytime blood pressure for the ambulatory blood pressure. So you can see that 135 here and then 135 there for daytime ambulatory blood pressure. Out of office BP measurements, as I have mentioned, they are recommended when a patient comes in and the in-office BPs are, high or high normal. You're not sure, as I've already mentioned, or in patients who you suspect have hypertension, particularly in diabetics. You want to rule out if they have max hypertension, or patients with fluctuating in-office blood pressure readings. So patients who are diabetic, patients who have chronic kidney disease, or in a patient who you suspect is non-compliant, then ambulatory blood pressure monitoring or out-of-office blood pressure reading will come in handy to help you to phenotype the high blood pressure. So if we divide this whole blue space into four by these two lines, you realize that when a patient comes to the office, you check the blood pressure and it's above 140. But you do an ambulatory blood pressure reading and you are getting anything less than 135, then this patient qualifies to be termed or classified as white coat hypertension. So in the office, BPs are high, but at home or when you do ambulatory blood pressure, the BPs are below 135. The opposite is here, where you measure blood pressure in the office and it is more than 140. So I'm talking about the upper quadrant. It's more than 140. But you do ambulatory blood pressure monitoring, and again, it is more than 135. Then this patient is truly hypertensive. If it's the case that the patient comes to the hospital and the blood pressure is the max hypertension, you do an ambulatory blood pressure reading and the blood pressure, the reading is high, but in the office, the blood pressures are low, then you consider this patient as having maxed hypertension. Of course, if you did both office and it's less than 140, you did ambulatory and it's less than 135, then this patient is normal tensive. So the out of office BP readings help corroborate the story, as in if you are truly hypertensive or not. And these classifications of phenotypes are not entirely benign. You can see that white coat hypertension, for instance, it occurs in about 30 to 40% of people who have elevated office blood pressure. The prevalence is lower with repeated office BP measurements or when a physician is not involved in the blood pressure monitoring. In such cases, ABPM, that is ambulatory blood pressure or home blood pressure monitoring, are recommended as mentioned. Max hypertension, 15% of people with hypertension have a normal office blood pressure. It is associated, it's not benign, it's associated with increased risk of dysglycemia, dyslipidemia, hypertension-mediated organ dysfunction, hypersympathetic activity, and even the development of diabetes as well. It does carry some risk of cardiovascular events. So it's important to phenotype these patients because they are not entirely benign. In this Japanese trial that was done, you can tell that patients who had normal blood pressure when compared to those who had white coat hypertension. The risk of cardiovascular events in these patients was, if you like, similar. But clearly, if you compare those whose blood pressures were uncontrolled, those who were labeled as max hypertension indeed had events similar or even more than those uncontrolled. So, in summary, if you have white coat hypertension, your event rate is comparable to somebody who is normal. So it is less benign. But if you compare people with uncontrolled high blood pressure, then if you had max hypertension, your risk is either about the same or more, as demonstrated in Japan. Blood pressure needs to be accurately checked. A cause for a quiet environment, patient having rested, patient refrains from any smoking, any caffeine intake, any form of exertion. Patient should be well rested. And then it's important to check the blood pressures in both arms for the first time, if it's the first time you are checking blood pressure, and subsequently you use the arm with a high blood pressure going forward. And indeed, you need to take a couple of readings about a minute or two apart. And it's also important to select the right calf size. So as I mentioned, your feet or your feet have to be bare on the floor, or they have to be rested on the floor, not crossed. Your arm has to be at heart level. Your back has to be supported. So if you look at this, you can tell that most of the blood pressure that are checked in our various institutions are not properly done. This is important because you can get some erroneous readings with when the bladder cuff is too tight or too small. Example, using a pediatric cuff on an adult, it could lead to increases in blood pressure of up to even 40 millimeters of mercury. If you put a cuff on clothing, sometimes people just put the cuff on the shirt of patients without taking them off. That could seriously increase the blood pressure by as much as 50 millimeters mercury. If your feet is unsupported, crossing your legs, that can shoot blood pressure up as well. Of course, if you're not relaxed and you're stressed, that can shoot blood pressure up erroneously. And if decisions are taken on these erroneous readings, you can imagine that the effects and the outcomes could be catastrophic. Of course, if you're smoking, you have to stop. If you have a full bladder, which, in some cases may even come with pain, that can also shoot your blood pressure up. And of course, caffeine, as we have mentioned. So the first fact is a single office blood pressure reading is sufficient for hypertension diagnosis and treatment control. I think at this point you all agree with me that a single reading may not be sufficient to diagnose hypertension. Again, the fact number 2, BP target, the lower the better. Is that true? Is that false? Or we don't know? You can tell that there's this kind of linear relationship in high blood pressure, so that when you have at least a 20 millimeter increase in your systolic blood pressure or a 10 millimeter increase in your diastolic blood pressure, it carries with it a several fold increase in your risk of developing cardiovascular events. So clearly, the higher the blood pressure, the higher your risk of developing cardiovascular events. And this is one of the things that should inform our tendency to treat patients, because clearly the higher the numbers, the higher the cardiovascular risk. So blood pressure reduction is key in terms of the therapeutic goals that we have in treating high blood pressure. The reason is because the blood pressure reduction, correlates with target organ damage and metabolic protection. Again, it does correlate with cardiovascular event or the risk of cardiovascular events. So almost all the guidelines, always advocate treating targets for the most part for, in the young, you are looking at targets of 130 systolic or below. As much as possible, the patient can tolerate, you can even come all the way to 120, But with some studies that have shown that if it goes too low, then you may compromise perfusion to vital organs. And even in the elderly, they may feel dizzy, some may fall, there may be collapse, there may be head injuries and all of that. So it's important to always target this sweet spot. before as you embark on your therapy. In the elderly, those above 65, there is some evidence that, blood pressure within the range, if you target anything between 130 and less than 140, as much as tolerated. So the key thing is tolerated. It's not because we are saying you should hit 130 or below. So in the elderly or somebody who is 75, who is dizzy at maybe 130 or 120, you still keep the medications at the same dose. You need to review such individual. And indeed, these are recommendations, but at the end of the day, patients have to be profiled individually. The SPRINT trial, as we all know, was done in almost about 10,000 individuals whose blood pressures were more than 130, but these are individuals who didn't have diabetes, and you can tell that, and they were followed up for years, as you can see, about 5 years here. And then the standard, those who were on the standard arm, the BPs were, between 130 and 140, as you can see, but the intensive arm, they were titrated or randomized to blood pressure readings that have to be around 120 or below. So you can tell from this schematic. And what were the findings or the outcome? You realize that primary outcome, which is a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, or cardiovascular death, in the intensive arm was better, or the hazard or the risk of developing all these things was lower in those who were in the intensive arm compared to those who were in the standard arm. Same for death from any cause. It was better for those in the intensive arm compared to the standard arm. So reduction in relative risk with intensive arm, as you can see, 25% relative risk reduction here and 27% relative risk reduction for death from any cause. And indeed, death from cardiovascular causes was reduced by as much as 43%. Again, standard compared to intensive, primary outcome was in favor of the intensive group, as much as 17% relative risk reduction. So in this meta-analysis as well, clearly the lower the blood pressure, the lower the decrease in blood pressure if you compare to, let's say 120 to 124, the lower you came or the lower the blood pressure was, the higher the benefit, or if you like, the lower the hazard ratio for developing cardiovascular disease. Same here. The lower the blood pressure readings, they favored lower incidence rates of cardiovascular events. And as I mentioned, there's a sweet spot of between 120 and 140, or if you like, less than 140 for systolic and less than 80 for diastolic. Because there is evidence, even in the SPRINT trial, that those whose pressures were too low, some had some complications like renal dysfunction and others that I've mentioned earlier on. So fact check number 2, BP target, the lower the better, cannot be the case because there's a range that needs to be targeted. ARBs better than ACE inhibitors at reducing blood pressure, and this is BP reduction. ARBs better than ACE inhibitors. And the evidence from this Cochrane review, which looked randomized controlled trials that evaluated BP lowering efficacy of monotherapy versus placebo. So we had about 92 trials which were based on ACE inhibitors, 14 different ACE inhibitors. And then these patients have baseline blood pressures on average 157 compared to ARBs, 46 trials, which comprise nine different ARBs. So the patient characteristics: office blood pressure more than 140/90, no restrictions in terms of age, comorbidities. They excluded patients with renal failure. And then you realize that whether you give an ACE inhibitor or you gave an angiotensin receptor blocker, you were doing similar BP drops. That is about 8 millimeter mercury reduction in your systolic blood pressure and about 5 millimeter mercury reduction in your diastolic blood pressure. So the conclusion is that BP lowering effect of ACE inhibitors and ARBs are similar. So the question is false. The next fact, number 4, is are ARBs and ACE inhibitors, are they equivalent in reducing all-cause mortality and cardiovascular events? So we have answered the question whether their BP reduction potential is comparable, and that we have said is comparable. Next question is, does that translate in an equivalence in terms of reducing all-cause mortality and cardiovascular events? So we will look at the data, and this study that was done called the on-target design, where an ARB telmisartan was compared to an ACE inhibitor, ramipril, and in another group or in another arm, they looked at a combination of ARB and ACE inhibitor. So when you combine an ACE and an ARB, what was the effect on vascular disease or high-risk diabetics and other patients who were not necessarily hypertensive? So we have telmisartan group who were randomized to 80 milligrams daily, ramipril 5 milligram daily. After 2 weeks, it was increased to 10 milligrams. And those who were on the combination of an ARB and an ACE inhibitor. Primary outcome was death from cardiovascular causes, myocardial infarction, stroke, hospitalization for heart failure. So it was designed as a superiority trial, telmisartan versus ramipril, which is superior, and not a hypertension trial per se. And at the end of the day, you realize that upon several years of follow-up, there was indeed no difference. The curves did not separate between telmisartan, ramipril, and the combination. Of course, there are some differences, as you can see over here, but the primary composite outcome was similar. However, when a subgroup analysis was done where they looked at those patients who had ambulatory BPs done for them, so they said changes from baseline in hourly means for systolic BP at 14 weeks, you realize that telmisartan did a better reduction compared to ramipril, a difference of about 3.7 millimeters mercury. This was also looked at where they compared the BP reduction, telmisartan, ramipril, and then a combination therapy. You can tell here that telmisartan is doing clinic BP of 135, 136 over here. It's doing daytime systolic blood pressure 126, which is lower than ramipril of 128. Same for nighttime blood pressures of 117 against 121. So the commentary is that the overall equivalence marks some trends which could be of concern. Favorable trends for stroke in the telmisartan arm explained by superior BP lowering effect compared to ramipril. So if you look here, almost all the confidence intervals are crossing one, which is making them non-significant statistically if you compare telmisartan with ramipril. But it is said that in stroke specifically, there was some trend or signal towards benefit in favor of telmisartan. And I think the postulation here is that because of this 3.7 BP drop that telmisartan achieved, then that may be the reason why there was some signal in favor of stroke. So the conclusions are that telmisartan indeed was non-inferior to ramipril for cardiovascular benefits in patients with vascular disease or high-risk diabetes, and was associated with less angioedema compared to ramipril, one of the side effects. Telmisartan had a better 24-hour BP profile with a greater BP reduction compared to ramipril, which we saw the curves separating. The combination of the two drugs was, however, associated with more adverse events without an increase in benefit. So once again, shooting down the notion of doing a combination therapy of an ACE inhibitor and an ARB, it came at a cost of events when really you are not deriving commensurate benefit. In this meta-analysis again, ACE inhibitors and ARB effects on all-cause mortality. If you remember, we looked at the effect of ACE inhibitor ARBs on BP reduction, and we said they were similar. This meta-analysis looked at the effect of almost all the ACE trials which were done compared to all the ARBs, the trials involving ARBs. And they looked at the treatment effect of this in terms of reducing all-cause mortality. And you can tell that the treatment effect was significant for ACE inhibitors in terms of reducing all-cause mortality. But same cannot be said of a angiotensin receptor blockers. As you can see, the P is not treatment effect for the P value for treatment effect was not significant. Again, the forest plot here crossed the line of unity. So in terms of all-cause mortality, the preponderance of data favors ACE inhibitors. I think Dr. Lubachi touched on this, the ARB paradox, where you realize that ACE inhibitors compared to comparators, and then ARBs compared to comparators. For some population of patients that were studied, there was an increased risk of myocardial infarction. And I think, as he has already explained, this is possibly explainable by the fact that when you give an ARB, you're only blocking AT1 receptors, you're leaving AT2 receptors and AT4 receptors. There's increase in pi levels, plasminogen activator inhibitor levels, tendency towards thrombosis, and tendency towards myocardial infarction. I think that is explainable from what has been mentioned so far eloquently. As you can see, ACE inhibitors clearly are doing a reduction in global death, CV death, stroke, myocardial infarction in these proportions, which we are not seeing in ARBs. The same here, if you compare ACE inhibitors to placebo, ARBs against placebo, you can tell that in terms of cardiovascular death or cause mortality, they don't cross. This one, for instance, cardiovascular death does not cross the line of unity, meaning it's significant. They looked about 62,000 people in high-risk patient among diabetics. All of them, you can tell that the hazard ratio, the confidence interval did not include one, making it significant. And if you come to ARBs, you can tell that all of them cross one, meaning that it is not significant, supporting the earlier slide that I presented. Again, some clinical endpoints were looked at comparing the effects of ACE inhibitors and ARBs, and you can tell that once they cross this line you're seeing is the line of unity, which is 1. You can tell that the red, which is ACE inhibitor, was favorable in terms of reducing composite outcome, cardiovascular death, myocardial infarction, stroke, all-cause mortality, new onset heart failure, new onset diabetes. But same cannot be said for ARBs, which is in blue, for cardiovascular death. And that is what the meta-analysis before showed. Again, same cannot be said for reducing all-cause death. So when you have to give medication that will reduce cardiovascular death, all-cause mortality, it is good to consider ACE inhibitors in the evidence of in the presence of the evidence we have. There was a head-to-head ACE versus ARB comparison for total mortality and cardiovascular outcomes. As we can see, the conclusion that ARBs are slightly better tolerated, but ACE inhibitors have higher quality data relating to preventing death, stroke, heart disease, and must be considered. Of course, the substitution of an ARB for ACE must be made in consideration of the weaker evidence for the efficacy of ARBs regarding mortality and morbidity outcome. So clearly, the data supports ACE inhibitors, but if patient for some reason is not tolerating the ACE inhibitor for some side effect or another reason, you can always switch to an ARB. At low doses, you can tell that the bradykinin and angiotensin pathways are dose dependent. So at low doses, for instance, both ACE and angiotensin receptor blockers, they have an impact on angiotensin levels. Indeed, angiotensin 2 levels drop once you put a patient on low dose ACE inhibitor. And it's been well explained because the angiotensin-converting enzyme will block angiotensin 2 from being formed in the first place. But when you put a patient on ACE inhibitor, there's accumulation of bradykinin, and we have looked at some of the endothelial benefits or nitric oxide benefits of bradykinin, which may be cardioprotective, I should say. This schematic has been shown already, and just to mention the fact that bradykinin accumulation is favorable in terms of being antifibrotic, anti-inflammatory, vasodilation, and the deleterious effect of stimulating an AT2, AT1 receptor will mediate these bad effects, vasoconstriction, all the way to increase in pi levels. So clearly, ACE inhibitor would lead to reduction in angiotensin 2 levels. When you do an ARB which blocks AT1 receptor, the levels of angiotensin 2 levels go up. Again, if you have a patient on an ARB, you stimulate AT2 receptors more, as you can tell. But of course, for ACE inhibitor, you are blocking the synthesis of angiotensin, so you don't get to stimulate either AT1 or AT2 receptors. There's accumulation of bradykinin in ACE inhibition. There's no change for ARB, as has been elucidated. So in terms of ARBs and ACE, whether they are equivalent in reducing all-cause mortality and cardiovascular events, I think the answer is no. Indeed, ACE inhibitors do better. So are all ACE inhibitors the same within the class? And similarly, are all angiotensin receptor blockers same within the class? It's a question that we need to answer, and we need, data to answer that. You can tell that from all these inhibitors, including perindopril to ramipril, they have different half-lives, they have different availabilities. Indeed, when you come to ARBs, it's the same, different half-lives, different bioavailability. Indeed, the half-life for telmisartan appears to be the longest here, which is 24, and the half-life of perindopril, which is about 17 hours or even more. Now, this trough to peak ratio is an index of the antihypertensive effect within the dosing interval. So if you give any medication, you want to see how long does its antihypertensive effect last within the dosing interval. If you're giving the medication for daily, that is every 24 hours, how long does the antihypertensive effect last? And you can tell that perindopril towers above all of them. Same can be said for telmisartan. So not all ACE or ARBs are the same, even in the same class. In this graph, same is speaking to what I have just mentioned, that clearly, if you look at medication like perindopril, amlodipine, telmisartan, these are medication with very high trough to peak ratios. And therefore, if you have to give any medication to the patient, you are looking at drugs which will do what they've been asked to do or what they purport to do, and they will do that for the most part within the dosing interval that they have been given. So all ACE inhibitors are the same within their class. Similarly, all ARBs also same within their class. The answer is an overwhelming no. Combination therapy is indicated for most patients with uncomplicated hypertension as initial therapy. Is this statement true, false, or otherwise? You can tell that adherence is key to achieving optimal BP target. Percentage of patients who were newly treated with antihypertensive who exhibited at least one or more periods of discontinuation. You can tell 62.8, overwhelming percentage of patients more than 18 years who were considered. Very few of them really were able to take medications without discontinuing, and it's the same here. So if these patients' adherence was monitored, you can tell that it's just around 1 in 5 or maybe 1 in 4 who are really adherent to the medication. So adherence is key. There's also ample evidence to show that all these studies that have been done from IDNT trial all the way to our heart studies, you can tell that patients are on at least 2 or more medications to achieve at least some BP control. So it's making the point that if you did a monotherapy compared to combination therapy, in this forest plot, you can tell that you were those on combination therapy had a better outcome or benefit in terms of any cardiovascular event. Same can be said for heart failure combination therapy, patient who has stroke combination therapy, ischemic heart disease, and even the overall effect of death. So clearly, initial and subsequent combination therapy was associated with significant reduction in the risk of hospitalization for cardiovascular events. And it is to support the fact that combination therapy is doing the trick, and the guidelines have gladly endorsed this position. Major drug combinations that have been used in various trials, some were compared with placebo or monotherapy. So some compared ACE inhibitors with diuretics, and that was in a progress trial which involved stroke patients, and you can tell there was a 28% reduction in the risk of stroke. Advance also, which compared ACE inhibitor with the diuretic among diabetic population. There was a 9% decrease in micro and macrovascular events. Hypertensive trial, which was done in the elderly hypertensive, also recorded a 34% reduction in cardiovascular events in terms of reduction. ARBs were compared to diuretics in this study in the SCOPE trial, which looked at hypertensives, which were more than 70%, and there was 28% reduction in non-fatal stroke. Now, if you combine an ACE with a calcium channel blocker, as was done in the older population in with isolated systolic hypertension, there was 31% reduction in cardiovascular event. This was done is the systolic Europa trial that was done in Europe. Similar thing was done in China, I should say, and they were done in the older population, and there was benefit in terms of risk reduction. In terms of combining two RAS blockers, so you're either combining ACE with an ARB, or a ACE-ARB with a renin inhibitor. Indeed, there were more renal events in this population, and the side effects were not tolerated. So, on target trial and the attitude trial discouraged the combination of ACE and an ARB in the same patient. So guidelines have endorsed this position, and indeed they are suggesting that if you have a patient you want to start in a therapy, it's always good to do a combination therapy. That combination includes either an ACE or ARB plus a calcium channel blocker or diuretic. So combination right from the word go, because the lower we're able to get the blood pressure to target, the better the benefit for us. The only patients you may want to consider monotherapy, it's in low risk grade 1 patients or in the very elderly frail patient who you are careful to drop that blood pressure given its counter benefits. Again, if you put this patient on a medication, after 1 month, you review the patient is not on target, then you could do an ACE or an ARB plus a calcium channel blocker plus a diuretic. So triple combination. So you look for one tablet which has 3 drugs in it, three different mechanisms. If after 3 months this patient is seen and the patient is still not on target, then we consider this patient who is on at least calcium channel blocker, diuretic, and an ACE inhibitor for at least 3 months as resistant. And if you have resistant hypertension, then you may want to consider some other medication that may block other pathways, which we've seen, spironolactone, and even other diuretics or beta blockers, as the case may be. It's important to mention the point that beta blockers are specific indications. I mean, if you have a hypertensive who has come with a myocardial infarction and you have to choose medications, it's important to get a beta blocker on board, barring any contraindication, given the benefits of beta blockers in reducing major adverse cardiovascular events in the context of myocardial infarction. So what are the advantages of combination therapy in antihypertensive? So greater reduction in blood pressure compared to monotherapy. Again, you prevent, you reduce side effects like edema that comes with calcium channel blockers if you combine them with ACE inhibitors. Again, you also reduce side effects like hypokalemia or hyperkalemia that may come if you combine the medications, or the medications include, let's say, RAS blocker, then you are likely to prevent any hypokalemia that may ensue. So in terms of side effects and then clinical benefits, it is definitely better to combine drugs from different classes. Now, in terms of diuretics, are they all the same? There's a thiazide-like diuretics in dopamine clothalidone, and then the regular hydrochlorothiazide, which we know they have different. You can tell that the newer ones, which the guidelines endorse, that is the thiazide-like diuretic and dopamine clothalidone, have a longer half-life. You can see duration of half-life is 24 hours for clothalidone, up to 15 hours for indapamide. Duration of action is even better for the thiazide-like diuretics, indapamide, clothalidone. Again, is there evidence that they decrease morbidity and mortality as primary agent? For the hydrochlorothiazide, there's no evidence, but for indapamide and clothalidone, there is some evidence. Again, indapamide is more lipophilic. Its lipophilicity is between 5 to 18 fold higher than thiazide diuretics. Indapamide decreases response to sympathetic stimulation. Again, it decreases response to epinephrine-induced platelet aggregation. It is also renoprotective, and there is data to show that. As you can tell, and Dr. Dubachi mentioned the fact that pi levels, when they go up, they engender a prothrombotic state. Do these newer agents do that? The ND there means that there's no data suggesting that, but clearly there's data to show that the hydrochlorothiazides do that. Mainly lowers blood pressure through vasodilatation, and that is a yes for the thiazide-like diuretics. Effect on lowering blood pressure is strong for indapamide and clothalidone. So clinical trials with different diuretics, the AHAT trial, for instance, there was the use of clothalidone in the SHEP trial, the Mr. Fit multi-risk factor intervention trial, that's a Mr. Fit, which showed that there's a decrease in 41% mortality, and even 50% less in those with coronary artery disease. The comments, as you can see, a 28% risk reduction for coronary heart disease mortality. So there's some mortality data for this thiazide-like diuretic. If you come to indapamide again, the Harvard trial, for instance, showed a decrease in 30% or 30% decrease in fatal and non-fatal stroke. Again, 23% decrease in cardiovascular death. So there is mortality data. This is within stroke. Progress trial that used indapamide. It showed mortality benefit in terms of reduction in the risk of subsequent stroke, and it was doing about 9 systolic BP reduction in that order. There's also some data for hydrochlorothiazide. So clinical trial outcomes of combination with low dose thiazide. So Ascot used bendoflurazide, Accomplice used hydrochlorothiazide in these doses. And clearly all three trials were compared to an active comparator. They were always inferior to a comparator, and they were inferior to calcium channel blockers as add-on to ACE inhibitor. Right, so clearly the thiazide drugs don't show any mortality benefit compared to the thiazide-like diuretics. Now, this, I think, is about the only trial that has been done within the, sub-Saharan African continent, and this was done led by, Professor Oji in Nigeria, and it's called the CRO study. So the CRO study basically looked at it's a randomized single-blind comparison of dual combination therapy for lowering blood pressure. They looked at these combinations: perindopril plus hydrochlorothiazide, amlodipine plus perindopril, and amlodipine plus hydrochlorothiazide. So you can tell that for two of the arms, there was amlodipine, one with ACE inhibitor, one with a diuretic, and the third one was just ACE inhibitor with a diuretic. You can tell that when these patients, so blood pressure was checked, they did, and then 2 months, we followed up 2 months, 4 months, and 6 months later. You can tell that all the drugs that contain amlodipine 5 with perindopril, amlodipine 5 with hydrochlorothiazide, that is the black and the red, did a significant drop in blood pressure, as much as almost 5 millimeters mercury. And the one that did the least reduction is the one that had an ACE inhibitor alone with a hydrochlorothiazide or a diuretic, meaning that among blacks, calcium channel blockers really do a better job in reducing blood pressure, even more so when they are combined with a diuretic, as you can see on this slide. I think this also speaks to what I was talking about. So if you look at the differences, comparing amlodipine hydrochlorothiazide with perindopril hydrochlorothiazide, clearly the systolic decrease in blood pressure was significant over here. But if you compare amlodipine hydrochlorothiazide with amlodipine perindopril, because they all have calcium channel blockers and we're doing similar levels of reduction, the p-value was not significant. So in conclusion, the CRO trial showed that amlodipine plus either HCTZ or perindopril is superior to perindopril plus hydrochlorothiazide in reducing blood pressure among blacks within sub-Saharan Africa with uncontrolled hypertension. So combination therapy is indicated for most patients with uncomplicated hypertension. I think the answer is an overwhelming yes. So this is a case study which you can briefly go through in the interest of time. 38-year-old man, school teacher, smoker, mother died of stroke, had hypertension, again, past medical history, significant for hypertension. He's on Bisopolo, he was on Bisopolo, but he stopped because of some dermatology condition and because of the fatigue that beta blockers also come with. He was not regular in terms of checking his BP and clinic visits. He complains of headache, fatigue, visual disturbance. His blood pressure is that high. It was rechecked and it's 170/100. The ambulatory BP that was done, high blood pressure, both daytime and nighttime blood pressure, as you can see. Current medication, he stopped his medication, he's not on any treatment. He's so overweight, as you can see, his blood pressures are high, and clearly he is obese. Some blood works that were done, his fasting sugar, as you can tell, is in the impaired range. Cholesterol levels were also high. So clearly some considerations in this patient, as we do in our day-to-day practice: high cardiometabolic risk, poor compliance in the past, multiple risk factors from smoking, cholesterol, prediabetes, in that order. So expected difficulty in controlling this blood pressure because of the insulin resistance, poor adherence, and severe hypertension. The patient also had a suspected obstructive sleep apnea. And this patient also went on to do carotid Dopplers, ultrasound, all of which are suggesting some intima thickness. And then he did some sleep studies. He did an echo showing concentric left ventricular. So this patient is a multi-comorbid patient. This is the polysomnography, where you see that the patient's heart rate, there are times that the patient's breathing practically stopped, and when it stopped at that time or stopping, his saturations dip, as you can see over here. So he had several of those episodes, and if you compute his apnea-hypopnea index, it met the criteria for obstructive sleep apnea. So this patient's risk, needless to say, the risk assessment by score is very high risk, and this patient clearly has to be treated in light of his dyslipidemia, prediabetes, obstructive sleep apnea, and the evidence of target organ dysfunction. So combination therapy is important in this patient. His sleep apnea, obstructive sleep apnea, has to be managed with a CPAP, and of course education on diet, and even remote monitoring through e-health. This patient needs to be followed up, and after 6 weeks, his blood pressure dropped to 156/84. So the plan was to switch to triple therapy and then follow this patient up in 6 months. Consider the addition of spironolactone. So fact number 7, which is the last one: ACE inhibitors and ARBs have reduced efficacy in Black patients with hypertension and should not be initiated routinely as monotherapy. And clearly, the guidelines have medications that are first line, that's the thiazide type diuretics per the 2017 AHA guidelines, American Heart Association guideline. Let's look at the current 2018 European Society of Hypertension, European Society of Cardiology. So they are recommending the thiazide-like diuretics, as we have seen, a calcium channel blocker with a RAAS blocker, as the case may be. And for Blacks, because of the risk of angioedema, ARBs may be preferred in that order. So the practical recommendation for treating hypertension in Blacks is that initiate Black patient on single pill combination therapy Rationale is that most Black patients will need more than one antihypertensive agent to achieve BP target of less than 140/90. The use of ARB rather than ACE in a single pill combination formulation may be preferable because there's a higher incidence of angioedema in Black patients taking ACE inhibitors, even more common among females. So use of calcium channel blocker in a single pill combination therapy may be preferred, as we've seen in the CREO study that was done in sub-Saharan Africa. Indeed, higher prevalence of diabetes in Black people, and there is the potential for diuretics to worsen glycemic profile. So Black people are at higher risk for heart failure, and diuretics are superior to calcium channel blockers in that respect. So ACE and ARBs have reduced efficacy in Black patients with hypertension, should not be initiated routinely as monotherapy. The answer is no. So in conclusion, ACE and ARBs both lower blood pressure, but only ACE inhibitors have shown reduced all-cause mortality and cardiovascular event. The quality of evidence within each class of ACE inhibitors and ARBs varies regarding BP lowering, 24-hour variability, and all-cause mortality. Combination therapy is essential to achieve currently recommended BP target for most patients, especially due to high rates of uncontrolled hypertension. I think I'd like to end here, and then I think we can take any questions if there are. Thank you very much for your attention.
Thank you so much, Dr. Lambert Etiapia. So grateful for this insightful presentation. So before the Q&A, we'll have a brief presentation by Sevier. So I'll be taking us through that in the next couple of minutes. So both facilitators, Dr. Edubuachi and Dr. Lambert, have laid solid pathophysiological differences and also relevant clinical evidence trials differentiating the ACE inhibitors and the ARBs, and also the superiority of ACE inhibitors and ARBs in relation to reduction of all-cause mortality. And we at Servier have our star ACE inhibitor, which is perindopril. And Dr. Lambert also made mention of the fact that single pill combination is the way to go in reducing CV events or providing that early CV protection and also increasing tolerance. So we at Servier have the combination triplex, which is our triple therapy for more power. And triplex is actually it contains perindopril, arginine, amlodipine, and indapamide. And we'd also have the dual therapy, which is Coveram, that's perindopril, arginine plus amlodipine, and also our monotherapy for a frailer patient, which is Corvisol, that contains the plain perindopril, arginine. Also, Dr. Edubashi laid solid foundation about the pathophysiology of ACE inhibitors. And also, it's worth noting that Corvisol has a unique pharmacological property of it being highly lipophilic. And he made mention of the fact that you have most of the over 90% of the ACE enzyme in the tissues. So you would need a molecule that is highly lipophilic to penetrate the tissues in order to inhibit this enzyme, making perindopril arginine, which is Corvisol, offering a better BP reduction coupled with an increased vascular selectivity. Also, with a TP ratio, I wouldn't bore you with this at all because Dr. Lambert threw more light on that. So Corvisol also has a high TP ratio, which means that it's able to provide that true once daily dosing for your hypertensives. So you wouldn't have your hypertensive being rushed to the hospital, usually during the morning between 4 a.m. and 8 a.m. because of maybe an hemorrhagic stroke or the likes. In addition to this unique properties is also that the significant arterial properties that Corvisol presents with, and our able facilitators have shed light and then educated us on the clinical evidence on all this. So just a recap, about cortisol's ability to restore endothelial function and also reduce arterial stiffness, as well as preventing of the early onset of atherosclerotic plaque, and also in correcting LVH, preventing cardiac remodeling, and also controlling the central aortic blood pressure, which is the pressure in the brain, the heart, and the kidneys. So all these unique characteristics also, our facilitators did an excellent job with this slide as well. They shed so much light on the morbid mortality trials. However, it's worth noting that it is only perindoprol arginine that can boast of 6 solid morbid mortality trials, of it having a positive endpoint. So you look at pre-MI, where perindoprol had the ability of reducing the incidence of LVH, and in progress, also reduction of the incidence of secondary stroke. And you look at Europa and HIVET, and also our facilitators spoke of advanced and ASCOT as well, with perindoprol's ability in reduction of cardiovascular events in the study population. So you realize that it is only perindoprol that had positive primary endpoints in all these morbid mortality trials. So for your hypertensive patients that require a monotherapy, or for your frailer patients requiring a monotherapy in the management of their hypertension, we at Servier have Cortisol. So Cortisol is the power in monotherapy. And with just 1 tab per day, within 3 months, your hypertensive systolic BP would be reduced by 22 millimeter mercury. And even with those with microalbuminuria as well, within 1 month, you would realize there's a regression in that. Cortisol comes in 2 available dosages. So we have the 5 milligram and the 10 milligram, and it's taken 1 tab per day before meals. For your hypertensives, poorly controlled on amlodipine only, or those you would want to initiate a single pill combination on, which we've spoken at length about it, we have Coveram. So Coveram is our reference dual therapy to speed up with power. So Coveram is a combination of perindoprol arginine and amlodipine, and it comes in 4 flexible doses. We have the first dose being perindoprol dose, and the second being the amlodipine dose. So we have Coveram 5-5, 5-10, 10-5, or 10-10. Also, with just 1 tab per day of Coveram, you are able to achieve up to 42 millimeter mercury drop in the systolic BP of your hypertensive. And also, not just the blood pressure reduction, it also provides a powerful cardiovascular protection, as foreseen in the ASCOT trial, where the primary endpoints which were measured were the reduction in cardiovascular mortality, kidney failure, and also total mortality. And you realize that Coveram provided a reduction in all these endpoints. However, 16 years down the line, this same study population were monitored as well, and that's the ASCOT legacy trial. And you realize that this population still had a 21% reduction in cardiovascular mortality. So last year, ASCOT was 20 years. And then a trial was done again with the same population. And then again, there was a reduction in the incidence of stroke and cardiovascular events. So this further proves the fact that Coveram has the tendency of offering a short-term and long-term cardiovascular protection for your patient. So if you prescribe Coveram for your patient, you offer them that short-term and long-term cardiovascular protection. So I believe edema is one of the side effects about amlodipine. Reason being because it only dilates the precapillary arterioles. However, so you would have fluid moving into interstitial spaces causing this edema. However, with a powerful combination of amlodipine plus perineal arginine, which is coveram, you would have perineal also dilating the port venules as well. That's normalizing the pressure in there. So oftentimes you would have patients poorly controlled on dual therapy as well. So for these patients, we have triplex, which is the triple therapy for more power. Triplex contains perineal arginine, which is the most preferred of the RAS inhibitors, I must say, and also the CCB amlodipine and the thiazide-like diuretic indapamide. It also comes in 4 flexible doses. So we have the first dose being the perineal dose, the second being the indapamide, and the third being the amlodipine dose. So with just 1 tab per day of triplex within 3 months, your hypertensive patient's systolic BP would be reduced to up to 54.4 millimeter mercury, and this is really significant. And also with their diastolic BP, there'll be a reduction of up to 19.6 millimeter mercury. Also, it has been proven in the advanced CCB, which Dr. Lambert shed light on, of it having an unparalleled cardiovascular protection, up to a 28% reduction in total mortality. So I made mention of 4 flexible doses of triplex. So usually we combine the lowest dose of perineal arginine to the lowest dose of indapamide, and also the highest dose of perineal to the highest dose of indapamide. The reason being to counteract the hyperkalemic and the hypokalemic side effect that ACE inhibitors generally presents with, and also the thiazide-like diuretics. And this is combined with either 5 milligram or 10 milligram of amlodipine. So I would pause here for comments, questions, so we can delve into our Q&A. Thank you very much. So thank you very much, Dr. Yao Dubuachi and Dr. Lambert Tetiapia, for such insightful and educative session. We might say we are privileged to learn from you too. Thank you very much. So we have the first question from Dr. Baswa. So Dr. Baswa is asking, in patients with MI, I believe, which RAS blocker is better, ACE inhibitor or ARB? So I believe this would be to Dr. Edubuachi on the pathophysiology.
So I just hope the audience was following, because I'm sure we,
Exactly.
we we had answered this question as part of the check finding facts. So
Exactly.
when it comes to myocardial infarction, the evidence is in favor of ACE inhibition.
Okay, thank you so much, Dr. Dubuachi. So I believe Dr. Baswa probably joined latter part of the presentation. So this to from Dr. Boy. Thank you for the presentation, Dr. Edubuachi. And from Dr. Cooper, in a hypertensive patient with diabetes, which is more protective, ARB or ACE inhibitor? I believe this can go to both facilitators.
Yes, in a patient with diabetes.
Diabetes.
Yeah. So I mean, I think so far it's important to risk profile your patient. I'm sure your patient will have some DM nephropathy or some even risk for coronary artery disease, in which case the data is clear that if you want just a BP reduction in these folks, you could use any of them. But if you're looking at drugs that will go on to reduce any risk of myocardial infarction, protect the kidney, reduce proteinuria, ACE inhibitors have been demonstrated in the HOPE trial where Ramipro was used.
Hey,
There's a lot. There's a lot for supporting ACE. The only one I may want to mention probably is where ARBs were also used in the life study where losartan was used. So there's some data for both, but the preponderance of data favors patients who were put on ACE inhibitors, given what has been elucidated. Thank you.
And also, if I have to add a little, I think usually it's also more important to look at these patients from the light of diabetes by itself is a risk factor. But like when we looked at the pathophysiology, you see, when it comes to treatments, you treat by pathophysiology. So if you look at a patient who is diabetic, especially a type 2 diabetic, then you begin to realize that the underlying factor is insulin resistance. And insulin resistance will then go through the pathway of metabolic dysfunction. So he'd have to, it's not as if the patient has an isolated diabetes, just like Dr. Lambert was talking about. But once the person has diabetic, if you look at the pathophysiology, you begin to realize that at the background will be all the thrombogenic effects, the platelet aggregation, the endothelial dysfunction. And for that reason, that is why it's easy for people who are diabetic, given 10 years, to become hypertensive. It's because of that endothelial dysfunction and all the background oxidative stress processes that happen. And if you look at that context, then it won't just be the diabetes to you, but you will look at the pathophysiology. And certainly with what we are presented today, you begin to realize that the evidence is stronger for ACE inhibitors compared to A when it comes to
Yeah.
all the therefore use that patient diabetes.
Oh, thank you so much, Dr. Lambert and Dr. Duboachi, for that answer. So I believe we have another question. So please, would you consider a patient with an isolated high diastolic pressure as hypertensive? And is the treatment approach the same with systolic hypertension?
Yeah. So I would say that it's one of the phenotypes of hypertension that has been described, particularly in the young people, where they may have diastolic blood pressures going up. But I need to say that a lot of these people are patients who are young, and therefore, if you embark on, some lifestyle dietary modification, some of these may come down without necessarily requiring treatment, unlike the isolated systolic hypertension, which happens for the most part as a result of the changes in the compliance of the blood vessel as you age. And there's been evidence, particularly if you take the HIVET trial, for instance, and even a SHEP trial, the systolic hypertension elderly program. Calcium channel blockers were useful in treating these patients. So what I would say that in that patient with isolated diastolic hypertension, this patient needs to be risk stratified. So whether the BP is up or the BP is the diastolic blood pressure, once the person meets the criteria for hypertension needs treatment, you need to risk stratify this patient. As has been mentioned, it's not just the numbers. What is the profile of the patient? Is this patient a high risk patient? If you apply a risk score, whether the Framingham risk score or the score or the pooled cohort equation, you're looking at the name, the age, the gender, the comorbidities, the lipidemia, and then those things that even the diabetic or diabetic status of this patient would inform what you go for and what you treat. So that is what I would say, because it's quite unusual to just have an isolated diastolic without any other comorbidities involved. So that's what I would say for now.
Thank you so much, Dr. Lambert. So, Dr. Ekia Osei, is angioedema associated with all ACE inhibitors?
Yeah, so pathophysiology wise, you expect that as you leave the bradykinins, you know, unblocked, you don't degrade the bradykinins, then you would produce the bradykinins that would begin to cause angioedema. But like I said, I mean, in real life, angioedema would be happening in about 1 in 1,000 patients. So it depends on the level of blockage of the drug to the ACE inhibition. But once you begin to get high levels of the bradykinins, you might get an angioedema with an ACE inhibitor at any point in time.
Okay. Thank you so much, Dr. Yahweh Duboachi. So I believe that's the last of the questions. Okay. Thank you so much. So thank you so much, Dr. Lambert. So that Dr. Lambert and Dr. Yahweh Duboachi. So that's we are done with the Q&A session. So before we draw the curtains, please could you give us some closing remarks so we can bring the CPD to an end? Thank you. So from Dr. Yahweh Duboachi, just maybe some few seconds, and then to Dr. Lambert. Thank you.
Yeah, I think we are grateful that as a platform for education, and certainly we have educated, we have also learned. I think going forward, I think the participants should now be able to appreciate that certain misnomers that people have had with respect to race inhibition, ARBs, we've been able to debunk quite a number of them by this fact checking. And I think the newer things that have come into perspective, especially the homologs of the ACE that will lead to the production of angiotensin 1 and 7. I think we should begin to look more into those areas and also begin to shape in our practice to for our patients to get more benefits. So beyond blood pressure control, I think our patients also have the benefits of blocking off all the other deleterious ones and enhancing on the other side the vasodilatory and then endothelial function, so that we end up preventing more cardiovascular events. So I think once we are prescribing, we should have that at the back of our mind.
Yes, thank you very much. I would also add my voice by saying that hypertension is a big issue, not just in sub-Saharan Africa, globally. It's driving our heart failure, driving our stroke, and other even renal conditions. So it's important that any opportunity we get to interface with patients, we do a proper blood pressure check. If we are not sure, you can ask the patient to check the blood pressure at home or can swing by a pharmacy shop, at least get some home BP readings going to corroborate the story. Again, if the patient can afford, there's ambulatory 24-hour BP monitors that are available with the cardiology, should I say, practice in country, which can be assessed. It's important to always diagnose appropriately. And once diagnosis is made, it's important to risk stratify the patient, check what attendant comorbidity the patient has, which will inform some of the medication that you will use. And if you so decide to treat the patient, it's important to do a combination therapy. As you have showcased, there are low doses of some of these drugs that can be used to reduce the side effects for the patient. And once we start patients on antihypertensives, it's important to monitor their blood pressures, give them at least 3 weeks, 4 weeks review days to come for review. Those who cannot afford, then that one, I think I will throw it back to you, Zelia, to discuss some cost mitigating measures that you may have in favor of the patients. Thank you very much.
Thank you very much, Dr. Edubuachi and Dr. Lambert. Yeah, so in relation to cost, oh yes, it's in discussion, and we are hoping to always bring the best to the patient, and also a cost-effective one for that matter. So yeah, so we'll revert accordingly. So thank you so much once again. We are really grateful, and I believe we can now enjoy the final minutes of the Ghana match. Though it's still goalless, we can still enjoy it. So thank you so much, and have a wonderful evening.
All right.
Yeah, thank you.
Thank you very much for the opportunity. Bye-bye.
Bye.